And we got Telesco.
All right, sorry, it's taking a little longer to go live than usual.
Thank you, Daniela. Good evening, everyone. It is 6:01 p.m. on September 28th. I'm going to call the Board of Health meeting to order. My name is Deanna Diamore, and I am the Director of Health for the City of Norwalk. It is 6:01. So I'm just going to do a roll call. So present, we have board members Ken Lalim, Terry Quell, Janet Karpiak, and Norman Weinberger. And we have Norwalk Health Department staff members, Teresa Argandesi, Bill Mooney, Brian Weeks, and Daniela Fignon. Did I get everybody? All right. The first item on the agenda is approval of the August 30th, 2022 meeting minutes. Do I have a motion? Terry, and then a second. I think Janet, you were second. Thank you. So, do we have any discussion about the minutes? All right, all those in favor, say aye.
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 Yeah, 4 ayes. All right, thank you. The minutes pass unanimously. Second item on the agenda is the director's report. I'm going to be really quick because we have a lot of other great updates coming further on in the meeting, but I just wanted to let everybody know that we do have community flu clinics that are scheduled. We have one on October 20th from 10 a.m. to 12 p.m. at the Norwalk Senior Center. And we have one on November 3rd from 5 to 7 p.m. at Brian McMahon. So I want to thank Norwalk Senior Center and NPS for their partnership and allowing us to use their great spaces out in the community for our clinics. I believe the registration will be posted soon on our website for people to sign up. So just wanted to let everybody be aware of those clinics. And I also wanted to share that, so Daniela Fignon, our Public Health Program Associate, she has been participating in a climate change, health equity, and public health law learning and practice collaborative with the Network for Public Health Law. She applied to participate. She's been a very active, she was accepted, very active participant. And because of her participation in that, they asked her to come to their summit, I believe it's next month, to present on climate and health equity and climate change. And so, and they're paying for her to go and present. And so we're really excited that she'll be presenting on climate and health. And she'll be having a special focus on a heat sensor project that the city has been partnering with Circa on. And she'll be talking about that project, and then also just the policy ideas and solutions related to heat sensors and how we can apply the data and move forward to address like heat issues within localities. So I just wanted to share that with everyone. I'm really excited and that Daniela was chosen to do that, and she's going to do a great job. She also presented on a webinar with Circa just, I think it was yesterday, talking about the project. So it's a great notice for Norwalk and great work. And you may recall that, Brian Weeks has been part of looking at, assisting with that project and mapping out the different locations, working very closely with planning and zoning and several other city departments. So it's been a great collaboration. So that's my report. Any questions?
That's excellent. I hope she's going someplace nice.
It's Minneapolis, so it'll be cold, but it's my first time, so silver linings.
Sounds great. Enjoy.
Right. Thank you.
Congratulations.
Thank you, Terry.
All right, the next item on the agenda is our COVID and monkeypox updates. So I'm going to pass it on to Brian to give his updates, and then Teresa's going to give updates after him. Brian, if you're talking, I can't hear you. Can others hear Brian? I can see your screen though.
No.
All right, yeah, Brian, you still can't hear you. I don't know if, do we wanna go to Teresa next? And then Brian, if you don't want us, like, stop sharing your screen and then maybe try to figure out the microphone issues and then we can go to you next. All right. Thanks, Brian. All right, Teresa?
Can you hear me now?
Oh, yes, we
Yeah.
can.
Yes,
Yep.
we
All right.
can. Good job.
All right,
Sorry.
sorry about that. I had to reset my headphones. I don't know what happened with the Bluetooth. All right, so I'll go through this quickly. So I was talking to myself for a little bit, but all right, so kind of the same old presentation using the COVID data hub. So that's what I was mentioning before. So hopefully it's coming up again. So I'll go through this quickly. Sorry again for that technical issue. So what we have right here again is the CDC community levels. So this is just a reminder kind of where things are at. Again, taking in consideration, you know, the more severe outcomes, especially burden on the healthcare system. Again, keep in mind it's a three-tiered system with the low, medium, and high. So Fairfield County has re-entered the medium category or level. We were just in the low for 1 week. And again, it's a weekly update, but we're back in the medium. And prior to that low, we were actually in the medium for 7 weeks. So you can kind of see how the trend's playing out. And again, just keep in mind what that actually entails. So just a reminder, the medium level entails those at higher risk of severe illness should talk to the healthcare provider about wearing a mask and taking other precautions. Those that choose to wear a face mask, that's still welcome. Especially if you're in indoor public settings that might not have, especially in consideration of those of mixed status in terms of a bunch of different things, you know, in terms of exposure and all that. Staying up to date with the COVID vaccine, getting tested if you have symptoms, you know, kind of those standard kind of prevention measures. So with that, you know, keep in mind kind of where we're at. This is the 7-day case rate for the big 7 Connecticut cities. You can see how some cities, like say, for example, Waterbury has seen an increase, a very noticeable increase. Norwalk, as you can see, did experience an increase. We were at 81, but now it's kind of jumped down a little bit as of late. You know, but it varies for each city and town. The important thing to keep in mind, again, is a lot of people are opting for at-home testing, which is not reportable. So therefore, that creates a gap or a gray area in terms of interpretation. So I just want to mention that, but this is the most recent data up to today, you know, as of 3 p.m. with the state releasing the new update. Hospitalization is going to obviously be one of the better metrics for us to kind of monitor. And as you can see, the most recent data point, we're at 384. You can see how we kind of did have a spike, you know, we were usually around that 340, 350. Then it went up to, you know, say the 370, 390, you know, it even hit the 400s, but now right now it's at 384. So something to keep in mind in terms of monitoring our situation, but you know, it is a little bit higher than usual. And again, this is kind of the aftermath of the Labor Day weekend, along with, you know, everybody's kind of routine setting back in, and also the fall time having started, where we're obviously experiencing this chillier weather. With full overall vaccination, with the most recent data from the State Health Department for all ages, initiated vaccinations about 89.41%. So it's been a gradual incline, or yeah, and all ages for fully vaccinated 80.44%. And then additional doses received for all ages about 44.01%. You know, this is just the state data, but the big thing here is watching and monitoring the wastewater data for COVID. And so this is for Fairfield County. As you can see, you know, we did have a gradual increase, and, you know, it did decrease a little bit with the more recent data points, but it's something we need to keep a close eye on. As you can see, the data point is up to September 14th because the contractor that is monitoring this did have also a holiday, an internal holiday. So the data is going to be catching up over time, and we'll see where we're truly at, you know, in terms of the circumstances. So I did want to kind of just put that out there. So with that said, you know, what has been kind of been the primary driver, as we've been familiar for the many weeks, is BA5. It's at, you know, for nationally speaking, from the CDC at 83.1%, with the most recent nowcast forecast from CDC for September 18th to the 24th. But, you know, as we can see, gradual increase over time is BA.4.6 at almost 12%. So it's something important to keep in mind, that we do have another subvariant that's slowly growing in proportion, and it's pretty evident here. BA5 had a kind of similar pattern where it was around for quite some time before it really started to stick its elbows out, so to speak, and really kind of then take over the show. So we'll see what sort of impact BA.4.6 does have, but it is anticipated that, again, it's going to be a little bit more infectious because of that success, just not as much as say BA.5 when compared to BA.2.12.1, when we had that kind of change in the status quo quite a few months ago. But it's something to keep in mind. And then we also have other subvariants too that also could be changing the trajectory of things, like the BA.2.75 and the BA.2.75.2, along with these other ones here. So looking at it from a regional perspective, you can kind of see how BA.5 is still the majority, but you can see how BA.4.6 has picked up in the Midwest, in the Southeast, and also just on the Eastern Seaboard, especially. So it's something important to kind of keep in mind. So with that, we also have to monitor and keep in mind influenza and the situation there. So you do have, again, the South and the Southeast really experiencing the largest proportion of influenza-like illness, Texas especially, Georgia and New Mexico, but also the District of Columbia. So obviously something on the Eastern Seaboard. Connecticut actually just a week ago was, a little bit higher in comparison to the rest of the Northeast, but as you can see, New York, Pennsylvania, New Jersey, even, a little bit of Rhode Island has picked up in that sense too. So it's just important, we are entering respiratory illness season. So that plays into not only getting your vaccines, but also being mindful of that and staying out if you're sick, not showing up to work and school and things like that, and activities like that. It's just going to be really important. And 'tis the season because we're going to have a lot of things, not only COVID and flu, but there's also RSV. We also have, the recent CDC HAN or Health Alert Network message regarding, enteroviruses, so enterovirus D68. Just as notice for anybody that's not familiar with this, this is a illness that can cause, high fever in young kids. The other big thing is acute flaccid myelitis risk, so AFM, and so that can cause, and usually it's precipitated by some sort of weakness in the limbs of children. So again, it emphasizes that message about prevention measures, monitoring, one's health condition, parents also monitoring their kids as well. Taking them to a healthcare provider if they suspect anything that is kind of out of the norm in terms of a high fever or any sort of limb weakness. That's going to be really important to help mitigate that in the community. So just want to emphasize that we have 'tis the season for many respiratory illnesses. With that, the monkeypox situation overall for the country, we're at 25,509. With that, though, Connecticut is at 125 currently. The largest proportion is California and New York. California almost at 5,000, New York falling around at 4,000. But this is this health department update, and this is from Tuesday, so it's showing 124. So just a difference of one between that timeline of yesterday and today. But as you can see, the largest proportion still by volume is Fairfield County at 42 monkeypox cases, followed by New Haven County with 35, Hartford County at 29. Age demographics or groups impacted, you still have the 20 to 49-year-old age group being the largest proportion, but as you can see, compared to our last update, the 50-plus-year-old age group did increase, and now it's at a volume of 13. Still pretty consistent in terms of gender, male being the majority gender impacted. And then race and ethnicity, you have non-Hispanic white at the largest proportion here in terms of volume, and then Hispanic 35 and non-Hispanic black at 28. So as you can see, the week over week kind of volume of cases, it's not as high as where we were with that 17 back in mid-August, but we still have kind of jumps here and there. Fortunately, in speaking about Norwalk, we have seen a slow number appearing. So it is consistent, in terms of not only locally, but also statewide and nationally. In terms of polio surveillance, I don't think I've mentioned this during one of these meetings, so I just want to mention this real quickly. This is a little bit older now, so but we still have not heard of any change. That the wastewater surveillance that is occurring for COVID is also monitoring for polio, and so far no detections have been indicated for Connecticut, given the emergency that New York has experienced with having actually human cases as well as detections of that in their sewage. The other thing I just want to emphasize too is just keep in mind that vector-borne disease is still an issue, even though it is feeling much colder, if not dramatically colder compared to the peak of the summertime. But we do have, and this is a recent update, 5 human cases of West Nile virus positive individuals. So I just want to emphasize that point because some of the two most recent ones are in Stamford and Greenwich. We had one of the older ones, actually the first one I think was in Milford, then we have the one in Wallingford, and now there's also one in Plymouth too. But you can see again the density of West Nile virus positive mosquitoes predominantly in the southwestern portion of the state. So not a great sign, something we have to kind of get through until we get to the first solid frost or freeze for the state. So just something else to just keep in mind as people go out in the community and go to events, especially outdoor events, which we want to obviously encourage to mitigate COVID and other respiratory illness risks, but at the same time, taking those prevention measures to offset the risk of mosquito bites and the potential risk of transmission of West Nile virus. The one upside I'll say is so far there hasn't been any detected EEE virus in the mosquitoes. Usually that comes from the eastern side of the state, and so that's been at least a plus here. And so far, the mosquitoes that typically transmit that have also not really appeared that much in this surveillance too. So that's a good sign that at least EEE is not rearing its head yet. So that's a silver lining here. But that's my update. Thanks.
Thank you so much, Brian.
Brian, you packed a lot of information into a 5-minute speech.
Yeah, thank you. Sorry, I was going for a little tongue twisters there.
That's good. You did a good job.
Thank you, Brian. Thank you, Ken. Does anybody have any questions for Brian? Dr. Karpiak, did you have a question? I think you're on mute.
Sorry, I didn't realize I was on mute. Brian, on the Enterococcus, regionally, are we seeing a presence in our area? Because I know we've had a number of respiratory enteros that, kids that have never been sick or hospitalized kind of getting hit fast and furious.
So I haven't heard of any enterovirus D68 cases in Connecticut per se. It's not saying that it hasn't happened. But this is just, again, an alert from the CDC just to make us aware of it, along with RSV and all these other respiratory illnesses. So tis the season. The other thing, just, why it's potentially concerning is because all the flexibility with the prevention measures that we had a lot more stricter and a little bit more, widespread, obviously more consistently spread. With the CDC community levels, that has kind of given a little bit more flexibility. People are obviously tired of the pandemic, so we have to kind of keep that in mind as we move forward into the winter time. There's going to just be greater risk of transmission. Not as much social distancing occurring, people opting maybe not to wear their face masks. And so want to remind people of what the CDC community levels do entail. Again, it is a matter of, just making the best decisions based upon the circumstances of, the events they may be attending. If it's going to be very close in terms of proximity to other people indoors, obviously the risk increases. And so again, it kind of emphasizes that spectrum of risk that we've mentioned in the past. And so people being mindful of that to offset the risk for EV, D60A, as well as, again, COVID, that we're all very familiar with and tired of as well. But yeah, it's
the mask came off. So, but being we've had a number of enteroviruses that would have been pretty severe. I knew that it was mostly in the southeast. I wasn't sure if it had worked its way out this way yet.
Yeah, not aware of it specifically, but I would presume, again, with travel, as we know with COVID, inevitably it makes its way around. And it's not a lot of physicians are not necessarily testing for this, so that's why it can't escape that surveillance too. So we have to kind of keep that in mind as well.
Thank you.
Are there any other questions? Thank you, Brian. I'm going to pass it on to Teresa now to give her updates.
Good evening, everybody. It's good to see you. So Deanna had asked me to give a quick update on where we are with COVID-19 education and outreach. And so I know that Megan has presented to you all regularly on the CAP program, but I just wanted to give you some highlights and share some more materials that we have available and some additional data. So I'm going to do a quick screen share. I promise. Let's see. Just make sure Is everyone seeing my full presentation or the presenter version?
Presenter.
Present, yeah.
All right, so let's do something different. Let's stop sharing. And see now, I have my two screens open. All right, this is what I'm gonna do. Share my screen. Run this way. No, I did it again.
Bruce, I think if you, yeah, there you go.
There you
That's it.
go.
Oh, that's you got, okay, good. All right, interesting. I learned something new every day. So, so just wanted to reiterate the strategies that our community health workers are using around COVID-19 outreach. So we are using data to drive all our activities at this point, and Brian and the community health workers and Megan have been working really closely. Brian has done an amazing job of supporting our efforts by mapping the vaccination rates in Norwalk and the other towns and geography where the CAP program covers. And then also assisting us with setting up a system so that we can map where we've done outreach, so that we can, you know, kind of match up where we're going door to door, where we're doing events, what businesses and organizations we're reaching out to based on the vaccination rates in those areas, and then looking to see where we've already done, what we've already covered geographically, so that we can then focus on areas, you know, and we can see that visually. So we're using that data to plan our activities moving forward and make decisions about which kinds of events and neighborhoods we can have the biggest impact. We're partnering with existing organizations and events. For any of you that have done outreach, you know that it's a lot easier to join an existing activity and kind of use that opportunity to address their audience versus pulling people to an event that's separate and standalone for your organization. So we've done some great work partnering with other agencies to reach people that way. We're trying to use both traditional and non-traditional education methods. So we have a lot of printed materials, a lot of information to give out, but we've also, the CHWs have done a great job of creating different fun, interactive ways to present information. We did some events at Norwalk Community College where we got a projector, and one of the community health workers created a Family Feud style game where there was trivia information or questions about COVID-19 and the vaccine. And so the NCC students and staff would come up to the table and they'd get to kind of chime in and answer the questions. We've also gotten kind of an analog version of that where we have a wheel that folks can spin right there on the table to figure out what questions we're gonna ask them. And then when they get the answer right, and sometimes even just for playing, they'll get a little prize. And so, you know, we have a lot of folks. What we've heard from the CHWs is that the kids that come to the table know a lot of information about COVID-19 and about vaccines, and they're always correcting their parents and their older siblings. So that's a fun finding. But one thing we have found is that the CHWs are most effective when they're doing in-person education and outreach. And so, you know, we have a lot of social media information that we push out. We have our website. But there really is no substitute for them out in the community, talking with folks, answering questions, being visible, and having the health department's logo and presence in the community. So they've done an amazing job with that. And they've also answered our vaccine information line. So folks who have made a decision, they want to get the vaccine and they need more information about where to get it, or they have questions. We have the community health workers are also manning that phone as well. One thing, in addition to the COVID-19 information that they give out, they also serve as a resource and a connector for other information and services. So we very recently had a meeting with our colleagues in community services over in City Hall who work at the Community Resource Hub, which is really a one-stop shop for Norwalk community members who have needs, whether it's around food or housing or assistance programs or education. The Community Resource Hub, you know, connects them with existing services out there in the community and refers them to what's out there. And so we just recently had a joint meeting with the Community Health Division and the Community Resource Hub, because we're both out in the community where, some of us are out there actively seeking out participants, and others, the Community Resource Hub has folks calling and coming into City Hall with questions. And so the more we can know the work that each other is doing, the better we can connect community members to what's out there. And then another example is monkeypox, right? So the CAP program and our community health workers are really focused on COVID-19 precautions and prevention. But what they do is they come back after events and say, a lot of people are asking about monkeypox, or, we had several people at this event asking when we're doing our flu clinics. And so what we've been able to do is provide them with information on some of those topics, especially the new and emerging topics that people are asking about, so that they can give out that information as well. So they're never going to say, sorry, I only talk about COVID. They're staying up to date and informed on a lot of other health topics, so that they're can be a resource. And then they bring back the questions that people are asking, the feedback that they're getting, so that we can clarify any communications that we're putting out, but then also inform future work. So they have come back to us with feedback about materials that we created that people found, were confusing or needed revision. Sometimes they'll get a lot of questions about, say, the testing site and over at Lockwood Matthews. And so then we'll be able to, communicate with the testing provider and say, oh, we're hearing some feedback about this, or, we're hearing that people would really like that. So we're able to use that feedback and the questions as a feedback loop, so that we can improve the work moving forward. So those are some of the strategies. And then I just want to share some pictures and some examples. So here we are at Norwalk Community Health Center, and I say we, but it's really, our CAP team. I'm just here to shout from the rooftops what a great job they're doing. So you can see here in the top right hand corner picture is the Family Feud game that Jake and his colleagues created, that really drew people over to the table and caused some competition among some of the students. In April, we were able to go to Earth Day, and so again, not necessarily a health event. Or a public health event, but definitely an opportunity to interact with community members and answer their questions. At the Juneteenth event on Norwalk Green, we held a Know Your Number screening. And so we were screening folks for different health conditions like high blood pressure and diabetes, but we were also there to provide information about COVID-19 vaccination and other precautions to help people as well. We've also been able to connect a lot of our community partners with Griffin Vans and other resources to hold clinics of their own. So often, we get invited to present information or to interact at events, but a lot of times the provider will reach out and say, I'd like to have a clinic at my organization. And so while we aren't going out and doing mobile clinics right now, we're able to connect them with the DPH Griffin Vans and serve as kind of like a liaison, and to then assist that clinic when it happens. This is another example at the Room to Grow preschool on East Avenue. That the September 23rd was their second clinic. They held one in August and then a follow-up one last Friday, and had really great success. Vaccinated, I think it was 17 people on the first day and 23 people on the next day, which these days is a really, really high volume clinic. And so it included a lot of kids as well. So it was great to see. And then just some quick notes on progress. So we have a quarterly report that we work on to kind of calculate how much outreach the community health workers have been doing. And so the most recent data, our next quarter will end on Friday, but for now, I have data for you up to June 30th. And so our community health workers attended more than 30 events in that 6-month period and engaged with approximately 1,200 individuals. And not that we can take credit for this entirely, but I just wanted to show as a comparison. I went back and looked at the mayor's report that Brian assisted with putting together. And, we're looking at January to June activity. And in January, the first report of the 2022, 83.33% of Norwalkers ages 5 and older had initiated vaccination. And then about 6 months later, it was up to 88.4. And then that same time frame, 72.9% of people were fully vaccinated at the beginning of the year, and 79.5% were fully vaccinated by the end of June. So keeping in mind that, the data is calculated slightly differently, it's all based on census estimates. So, it can vary over time for sure. And these aren't 100% precise, but just gives you an idea that, it does really make a difference when we're out there. There are a lot of people that haven't initiated vaccination yet, and then they, something comes up and they make a decision, and then they're able to get out there and get their vaccine. So I hope that to say that we've had a big part in this increase over time, and I know we have a lot more work to do, but just wanted to use that as an example of ways that we can look at our progress over time. And that's my update.
Very nice. Where by chance does the funding come from?
So the CAP program is funding from the Connecticut Department of Public Health. So you are all probably very familiar with our IAP program through Pam Bates and Sarah Forrestal, who do outreach and education for childhood immunizations, routine childhood immunizations. And so last year, the DPH was able to expand that program to have a focus, an arm of the IEP program specific to COVID-19. And so it's a very similar funding stream from the DPH immunization program.
Does that have some, excuse me, does that have some length to it? Some opportunity for expansion of that program?
Yeah, so the contract right now runs through next year to June of 2023. And we're looking at the possibility of extending it.
Great.
Thank you, Teresa, for that really great update. And thanks, Ken, for the question. Does anybody else have any other questions? Really great work. Thank you for sharing that with us, Teresa. Okay, so our next item on the agenda is the body care technical standards. And so I know we discussed this last month, and so we have provided the latest version of the technical standards, and I'm going to pass it on to Bill just to describe a little bit more about it, and then open up for any questions.
Okay, hi everybody. So the major changes that we were incorporating were just to include changes that occurred at the state health department level, where they changed some of the licensing requirements prior to 2021 rather. There was no requirement for all the nail technicians to be licensed, so they could work there. They had to go by sanitary standards and that type of thing, but there wasn't anything to really require them to be licensed. The states changed that, which is great. It makes them have to apply for it and go through a little process, and they give them a license. It's annually renewed. So that was the biggest thing. They also changed a couple of things where there is now a license for an eyelash technician. This is where generally when there's doing some extensions and this type of work for us, so they wanted to actually get these people licensed where they can have a little more control over them in terms of the sanitary processes. The tattoo license, they changed a little bit. They removed the requirement for a physician oversight. It used to be where a physician would have to sign off on their sanitary processes and making sure they were supposed to go in once a year, check the facility, make sure it was in good shape. That's no longer required. That was the biggest one. So they do go through a number of courses that they're required to take, first aid, and some other things. So they still have the same requirements, but they've just stricken that. So we had to change that one. And they've combined a couple of licenses, an esthetician's license. You can now get an eyelash technician, the nail technician under the esthetician license as a combination if they choose to do that. And that was kind of another addition to it. So those were the main changes. The most significant one for me, honestly, is the striking of the physician oversight in the tattoo parlors. I think that would have been nice to maintain that, but because they're not required, we're not gonna do it either at this point. So, and the other thing, and Terry had a couple of questions. Would you like me to address them the way you had them, Terry, or?
Sure,
Terry?
that's fine.
Okay, so,
Thank you.
yeah, sure. So Terry had asked about the janitorial sinks and that we had that they're when necessary. That was a good spot because it really should say that for cleaning, sanitizing and washing, not when necessary. I think what initially they meant by that was we want to have typically a hand sink, a sink for washing your utensils, and a slop sink or utility sink for washing the floor and that type of thing. Some places don't have enough space for that. So we allowed for them to do the washing, sanitizing and such with these instruments in the sanitary sink, or I'm sorry, in the janitorial sink or the slop sink, utility sink. I think that's maybe what they meant by that language initially, but it is a little confusing. I think it's best just to strike that and just say for cleaning, washing and sanitizing. It kind of removes that. So that was a good point. And I think as long as you're willing to do that, I think it would be a good idea. Then you asked about the disposal instruments and if they're sharps. There shouldn't be any sharps in there. Disposable instruments in the salons are files, buffing things that are one-time use will get thrown out. Anything that would have a sharps that would, let's say, permanent, where you're doing eyelashes that are permanent, that's under the tattoo license. You have to have that. So all of that would be under that same part of the ordinance or the technical standards that they have to have a sharps container and dispose of it as a biohazard. So there really isn't, they wouldn't have that in the scenario other than under a tattoo.
Okay, great. Thank you.
Sure. And then you had asked about the receptacles and the refuse. So the receptacles are those cover receptacles that we want inside the salon so that they'll dispose of stuff. The refuse are actually the ones on the outside. So that's the difference. Maybe it's a little subtle or nuanced, but that's what they meant by that. So there's the inside cover, the outside ones are covered also, but they're outside to be disposed of with the rest of the trash.
Oh, okay. I wasn't thinking that way, so I was trying to figure that out. Okay. I wonder if that should be clear. Does that ever come up as a question?
No, it hasn't.
Okay.
But that's okay. I mean, it's always worth, wondering about it. So, but no one's ever, I mean, maybe because when we do it, we know what the difference is, but if you didn't, maybe we could clarify it a little bit if you think that's necessary.
I just wondered because one said receptacles and the other one said refuse storage. And I was just, what else would you put in receptacles? I wasn't sure quite what that meant.
Yeah, we could maybe change that so that refuse maybe it's defined a little bit better, where it's the outside receptacles that are disposed of with the trash, if that would make it easier.
I don't know, maybe I'm the only one that thought it was unclear. I just wasn't sure what went there.
Okay. All right, well, whatever you all think you want to do is fine, but that's the difference. So the inside is the small cover receptacles, the refuse is those outside to be able to throw it out their garbage and whatever else they have as well. Okay. And the last thing, you're plumbing the water question. So the 110 is for what's required by the building code for hand sinks.
Right.
Okay. The 158 is considered a low temperature. I think what they wanted in that part of the ordinance, this was brought over when they first started this a number of years ago. It was brought over from some other, I think it was actually from Hartford Health Department that had already established an ordinance and technical specs. So they just kind of carried over from there. I think what they meant by the 158 was a number that would be considered low temperatures. You want to make sure whatever chemicals used to clean your linens and stuff are compatible with low temperatures. I think that's what the intent of that was. The 158 is a little bit of, I'm not quite sure why they had that. I know in the food industry, 160 is kind of where below that is considered low temperature. So we could adjust it to that number, but that was brought over from another health department initially. So we could change that if, I think it's not a bad idea, to be honest with you. And the 170, I've actually never seen this used. I think this is in the last kind of, if you don't have a sanitizer and you had to do something to sanitize, that would be the way to do it. We always have thermometers with us when we go out because we have to test the water temperatures at the sink and so on. They're required to have a thermometer also for the same reasons. I've never seen this used. Typically, if you have this sort of thing, you're going to use the barbicide. That is the best way to sanitize, or they can put it in, let's see, in a, I can't think of the word off the top of my head. It's a big unit that they use for sanitizing.
Yeah, I know.
Yeah.
I've
I'm
seen those. I know what you mean.
Yeah, so, so they could use that. I've never seen this. I think it's just mostly for the last resort, but I've never seen this used in 20 years. So we
Okay.
could strike it if you think that it's more of a confusing type of thing. I would understand that.
I mean, I don't know. I just, as I was reading through, I saw where, because the first in section 1, where it says hot water at any faucet shall not exceed 110 degrees Fahrenheit. So if that's not more than 110 degrees, then how do you get your hot water that you're washing your towels or whatever with up to 158?
Right, and that's where it is confusing. I think we could probably change this so that it's a little bit more consistent. I agree, because it doesn't make sense. Well, how would you get there without a booster? And you're not going to have that typically. You would in a restaurant, but not in a scenario like this.
Okay, I just was wondering because if you have hot enough water there, then how does your hot water only come out to 110 degrees?
Right, and it would still be a low temperature in which the chemicals would still have to be compatible anyway. So, so that's something we could revisit and change that. I mean, I think that all of these are good. It's probably, that's one section that you could use some clarification.
Okay. Okay, thank you very much. I appreciate it.
Sure, sure. Does anyone else have any other questions? Okay, thank you.
So I would ask if you guys would, if the board would feel comfortable with a motion to accept the revised technical standards with the revisions as discussed with board member Terry Quell. If we make those adjustments, if we clarify the receptacle versus the refuse, if we strike when necessary in that section, and if we make those changes as we just described with the water temperatures.
So moved.
So, do I have a
second that.
second? And Terry, a second. All right. Any further discussion? All in favor, say aye.
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 Any opposed? Abstention? All right, we have it passed. Great, thank you. Thank you so much, Bill, and thank you, Terry.
Yes, thank you, Bill.
Yeah, thanks, Jerry. Those were really good, some good points. So I'm glad that you brought them up. Thank you.
Bill, are you thinking with the term you were thinking about was autoclave?
Thank you very much. Yes.
Oh, there you go.
I was like, Rebecca, I know this thing. Thank you very much. Yes, that's what they use. They'll use that of the barber side. The barber side tends to be cheaper, and the autoclaves, you have to do a little maintenance work with them, but they usually use both of those and never hot water, but it's in there just in case. But thank you very much for bringing that up. I appreciate it.
All right, thank you, everyone. And the last item on the agenda before public participation is a strategic planning update. So I know I discussed this last meeting, but I did prepare some slides. So I just wanted to show that to you all quickly before we wrap up. That's okay. And I'm going to try to share my screen as well to see if I do this right. Can you guys see my slides, or do you see the presentation mode?
Your
Looks good.
slides.
The
We can
slides?
see them. Yep.
Okay, great. So as you all know, we're in the middle of updating our strategic plan, and the process that we've taken is to review our existing vision, mission, and values, review data and information to help inform the future direction of the department. We conducted a SWOT analysis. From the SWOT analysis, you then develop strategic priorities and goals. And then from there becomes, the more like the work plan, the action plan with the objectives, the action steps, the measures, the outcomes. And then after all of that comes the implementation. Right now, the phase that we're in is we're focused on developing our goal statements and also putting together that action plan. So I wanted to just give you, so go back a little bit from the beginning. So the vision, mission, values. We are in the process of updating our vision. So we looked at, what is the definition of a vision, it's a compelling and inspiring image of a desired and possible future. And so our current vision, which is excellence with efficiency, we met back in July with board members, staff members. Lamond was there, and we had a consultant helping to facilitate the discussion. And we thought, that our vision didn't quite match up to where we wanted it to be, and we thought it was a good time to make adjustments. So an internal group of staff has been working on making some changes to the vision. And so right now, this is our new draft vision: healthy Norwalkers thriving in a vibrant community. We thought that would be, more of that compelling and inspiring image of, where we want to be and focus more on our community. So that's right now our working draft of it's going to be our proposed new vision. We looked at the mission, and we thought the mission statement as it stands was still pretty good, and we thought it didn't require any changes right now. So we decided we wanted to keep where we are with our mission statement. Our values, though, we thought that it was a good time to make some adjustments to our value statement. So the first value statement, we're looking to incorporate edits to add health equity. So we're working on the wording for that. We wanted to add accreditation into these value statements, really demonstrate how we value that. And so we're thinking about adding something with accreditation within that second value statement. We wanted to add transparency. So that's where we add that within the third value statement. Community trust was a big theme that has come out in discussions. And so we thought it would be great to add that to the values. And then when we were talking about like workforce development, our value statement related to that was focused on our staff, but we thought it really needed to also focus on our great and amazing volunteers, as well as the future public health workforce. So that's where we are. So we feel like, 3 of the value statements were pretty much done with the wording, and we're feeling pretty good about that. And then the first 2, we feel like we still have a little more work to go. Part of the strategic plan process, I mentioned reviewing data and information. So Aniela and I worked on an environmental scan with also guidance from Megan. So we followed the process that was outlined in the National Association of County and City Health Officials Guide for Strategic Planning. And so an environmental scan, you can read on the slide, it's an analysis of meaningful data and information that focuses on community health, finances, internal strengths and opportunities for improvement within the health department, looking at the state and national perspective, and then also looking at learning and growth. So the purpose is that, help us identify our strategic issues and, the direction of the plan. This is just a screenshot of many of the data sources we included. I just wanted to show you how comprehensive it was. We included, for the community data, there's a Norwalk equity profile that's put together by Data Haven. We looked at our past community health assessment. We looked at the community health assessment that's getting updated right now. We looked at our community health improvement plan, looked at some surveys related to mental health in the community. For financial pieces, we looked at our data, with revenue and expenditures. We looked at both the city operating budget as well as grants, and then took a look at, what's coming down the line in terms of future grant opportunities. For that third section related to the health department, we looked at our own annual reports, both the ones that are completed for the health department, as well as the one that's completed for the state health department. We looked at a strategic plan progress report based on our past strategic plan and how we did with implementing it. We looked at all the feedback from a site visit report for reaccreditation. We participated in the public health win survey. So we looked at that data and we included that within that section, as well as that last section for learning and growth. The efficiency study, as you remember, we looked at those findings and what was specific to the health department. We conducted a community stakeholder survey. So we incorporated that information, as well as some after action reports. And then from the national perspective, there's been a lot of reports coming out the past year or two related to the future of public health. So there's several that we included that were really helpful to think about, where do we move forward and how do we continue to align with the national standards and the direction that we're moving in for public health. And I mentioned the public health win survey. So just as a recap, that looks at, what are the training needs for our staff? What are our current competencies? And then it also looks at, sort of like an internal stakeholder survey too, like how is the culture at the health department, and and so that was interesting too, to kind of benchmark us compared to others across the country. I mentioned the SWOT analysis. So we completed a SWOT analysis with that group that I talked about back in July. We had fun with some sticky notes and had fun with Jamboard. So this is just a screenshot of one of the pieces to that SWOT analysis. And then we went into prioritization, and we looked at this different criteria, several different criteria we looked at, but we asked people to think about, is it a core public health service function? Is it bringing value to our customers? What's important to risk mitigation? What's the return on investment, both from a financial standpoint as well as a health standpoint? Is it aligned with our vision, mission, values? That's the strategic alignment. And, how ready are we to move forward on this priority and on this issue? We used a prioritization matrix. So all of that different prioritization criteria I talked about, we assigned a weight for it. And then we talked about, potential strategic issues and how they aligned. We sent that out to staff and the board members that were part of that discussion as well. Everyone was part of that to figure out, how would they weight the different potential strategic issues against this. And so this is where we came out with the strategic priorities. And this is sort of ranks like how they came up with scores. So workforce development came up as the top. Public awareness and trust was the second issue to work on. Evaluation of our programs and services was third. Foundational infrastructure improvements was fourth, and technology was fifth. And throughout that, we talked about needing some areas to be cross-cutting and interwoven throughout. And so we said, health equity and climate change are things that we want to incorporate throughout our plan and really think about, how they relate to all and intersect throughout all of these different areas. So I just want to quickly say, for those, just to further clarify, so there's a lot of different topics, and we try to incorporate them within these broader themes. And so what do we mean by workforce development? We're talking about ensuring a competent, satisfied, and skilled workforce. So that could be training opportunities, professional development, recruiting people to our department, staff cohesion, our onboarding process. And then we also talked about burnout and employee wellness as well. For public awareness and trust, we talked about increasing public awareness of health department activities and services and enhancing community trust and engagement. So again, communications can fall under this, community awareness, that building that trust within the community, public perception, and community partnerships as well. Within evaluation of programs and services, this is sort of the catch-all, to really thinking about, assessing our current programs and services and determining future desired changes. So are there things that, should we be eliminating and thinking about not doing if it doesn't meet, community need anymore, if it's not efficient, what programs or services should we be adapting to be more useful and utilized? Do we need new programs and services to meet those emerging community needs? What partnerships can we be having with external organizations? And also taking a look at, staffing shortages. Within foundational infrastructure improvements, we're really talking about, those internal systems, processes, plans, and policies. So now we're kind of looking within, right? So how is our communication within our department? How are our collaborations, both internally and externally? What do we need to do to develop as an organization? And then some more specifics like funding and grants management, quality improvement, performance management, and all our SOPs. In technology, we're talking about hardware and software to improve the efficiency of our operations and to really expand our capacity. And so this is, a lot of the different findings from, the efficiency study and things that we've been talking about for years, right, within our strategic plan. So we were talking about our environmental health software, our financial software, the billing components, our electronic medical record, different requests and the way we do filing to get information out to the public, secure communications for private health information, protected health information, and really taking a look at modernizing our systems to collect, analyze, and share data. As we're talking about these strategic issues and areas of focus, I've asked staff to think about, as we're moving forward, we can lead a different effort, strategy, or action. We can collaborate with others on it. There might be something that we're not leading, but we could be involved in connecting to others to share our perspective and guidance related to that issue, but with more limited involvement. And there might just be things that we want to stay informed on, but we're not ready to take additional action at this time. So I asked staff as they're working on this to have that framework in mind. Right now, our goal is to put together these work plans and action plans. So that's like the template that we've provided. And we've set up work groups for all these different priority areas. So right now we have draft goal statements. Each work group, I believe, has met once, except for the climate change one, I think is meeting tomorrow. We're putting together draft objectives, strategies, and all the things that we've talked about within the work plan. And so we're hoping to be able to present this, finalize those draft work plans by the end of October, and then present it to you all either November, December, depending on the timing, to get your input. And I think that is
Very
it.
comprehensive. I have one comment related to workforce. I think that workforce retention is becoming such a huge issue, at least in the marketplace that I'm in the healthcare side, community health centers especially. Norman maybe able to echo this a little bit. Finding competent help and retaining competent help is paramount. We're finding that you can't treat patients if you don't have the bodies to treat the patients. Patients are there, the volume is there, but we have to maintain that. And so somewhere in that mix of stuff, I know it was kind of there in a few different places. I think is imperative to put some efforts towards retention of staff, because they just, we just find that we train people and they go to the hospital for jobs. So there's an issue related to compensation. There's a bunch of different issues. That's not the only one, but I would think that we need to incorporate that into our theories.
I agree. I totally agree with Ken. That's a critical issue in every medical facility around, and certainly part of it is compensation. But the other part of it is to let people know that they're doing a good job. And it's it's actually the little things. It's, saying, how are you? How you doing? Thanks for working with me today. And I think that's part of the issue with burnout. There's not time they're being asked to do so much that there isn't time to see if they're doing okay.
Thank you, Ken, and thank you, Norman. I completely agree, and I'm taking notes about that to make sure that we include that. Any other comments, suggestions, questions?
I think you guys did a great job. I enjoyed being part of it.
Thank you, Ken. Yeah, thank you to Ken and Terry. They were very active participants in our process. All right. Any other questions before we move on to public participation? All right. I don't believe we have any attendees. Aniela, is that correct? I'm not seeing anybody.
Yeah, I do not see anybody besides, let's see. Make sure. Nope,
I don't see.
no others.
All right, so I'm gonna close for public participation then. And then we'll be able to wrap up. Anything else? Okay, we will adjourn at 6:59.
Excellent.
Good evening, everyone.
Have a
Thanks,
good night.
everybody. Good to see you all.
Great work,
Thank you.
usual.
Bye, everyone.
Bye,
Take care.
everyone.
Nice to see
Good
you all.
job, everybody.
Thank you. Have a good night.